So the outline of today's presentation, and I'll introduce our speakers to you in a second. Have you ever wondered how public health units find out about outbreaks and then figure out what caused them? So Nicola and Michelle are going to go through the 10 steps of outbreak investigation. They'll explain each of those steps along the way. And they're also going to work us through a real life example that occurred in New South Wales. So that will really solidify the 10 steps and help you understand exactly how those 10 steps works. If you have any questions, you can add them to the chat or use the Q&A button, and Nicola and Michelle will answer those at the end of the presentation. There will be an opportunity for you to get involved in this presentation, so look for that when it comes up. We hope you enjoy it, and as we said, if there's any questions, pop them in the chat and we're happy to answer all those at the end of the formal presentation. So everybody, it is my pleasure to introduce Professor Nicola Stevens and Associate Professor Michelle McPherson, our very own public health superheroes. Nicole is the Director of the Public Health and Health Service Innovation Program at the Tasmania School of Medicine. She's an infectious diseases epidemiologist with a knack for tackling everything from antimicrobial resistance to environmental health. Nicola has held senior roles in public health departments across 3 Australian states and has even helped lead the charge against COVID-19 in Tasmania. And Michelle is the unit coordinator for 3 health protection units at UTAS and a communicable disease epidemiologist with a Masters of Applied Epidemiology. Michelle has worked at state, national and international levels developing and teaching workshops both locally and globally. She's also an editor for the Western Pacific Surveillance and Response Journal. When Nicola and Michelle are not busy saving the world, they are shaping the minds of future public health leaders. Thank you very much for your time this afternoon, Nicola and Michelle. I'll hand over to you.
Great. Thank you, Michelle. Thank you for that very warm and overdone introduction. So I'm Michelle, and myself and Nicola are going to walk you through the 10 steps of an outbreak investigation. This content is all based on what we teach as part of both our 4-day short course on outbreak management and also our unit of outbreak management, which you can do in a couple of different courses, which we'll talk about at the very end. But before we do that, let's go into the outbreak investigation. So I'm going to be introducing each of the steps, and then Nicola's going to be applying those steps to an outbreak that occurred in New South Wales. So step 1, the first thing that you need to do is detect an outbreak. So how do we actually find out about a potential outbreak? We typically have 2 main ways. The first is when we have an increase in notifications, and we use our indicator-based surveillance systems to help us with that. So for those of you that aren't aware, there are many diseases nationally and in each jurisdiction which must be reported to public health units. I think nationally there's just over 70. There's a whole range. COVID is one of them. There's lots of foodborne diseases. There's vaccine preventable diseases, many for different reasons, but lots are so that we can detect outbreaks. And what a lot of public health units do, as you can see in the figure here, is we monitor disease over time. And when we see any increases, we think, is there something going on? Could there be an outbreak? And that's when we start our investigation. Now, sometimes we might be notified of one disease, and that might indicate an outbreak. So if a doctor rang up and reported a case of Ebola, for example, we would start an outbreak investigation. So that's the first way. The second way, an event, should turn my phone off, of a potential outbreak event. So typically this happens in the public health unit at about 4:30 on a Friday afternoon. You'll get a phone call from a doctor, from a member of the public, somebody saying, look, there's been an incident or an event and now some of us are sick. The classic is the wedding reception. So last weekend we went to a wedding reception and now 15 of us are sick with a gastroenteritis. We then, as a public health unit, need to investigate that as a potential outbreak. So over to you, Nick, to talk through this example.
Great, thanks, Michelle, and hi, everyone. So you've received a phone call. You are the public health unit. You've received a phone call. Yesterday morning, a doctor called from a local ED to report an increased number of gastro cases presenting during the previous evening. So you as the public health unit interviewed those 3 cases on Friday afternoon, but you weren't able to identify any common exposures. So Michelle's just popped up a little quiz there asking, do you think it's an outbreak? And if we'd really like you to participate by popping in what you think. I can see, I'm not sure if everyone can see the poll going up. I think it's just us. I can see that you're answering. That's really great. Thank you very much. Okay, so where have we got to? A couple more still coming in. Here. Oh, okay. It's a bit of a race. So we've got couple more coming in. Great, everyone's answered the questions now. Can you please remind me, Michelle, can everyone see that, or is it just us, the poll?
I'm actually not sure, so it might be good just to quickly go through.
Yeah, I'll go through them.
What the responses are.
So your responses have been 24% of you have said yes, that you think this is an outbreak. 38% of you have said no, you don't think it's an outbreak. And 38% of you have said you're unsure. So a few of you think yes, some of you think no, and some of you are not sure. So pretty equal across those different answers. So let's have a closer look. Okay, so breaking news. The same ED department just called as there have been additional gastro cases presenting overnight. The ED nurse also said that several of the patients reported eating pork or chicken rolls from a bakery in the area. Do you think it's an outbreak now? We'll get you to repeat your responses again and see whether you've changed your mind a little. Thanks for being so speedy. I can see you're answering really quickly. That's fantastic.
And quite a different outcome this time.
A very different outcome this time. So now 86% of you say yes, you think it is an outbreak. Only 4% of you think that it's not, and 11% of you think you're still a little bit unsure. Thank you very much for that. Thanks, Michelle.
So just, I guess, when I've done this and when I can actually speak to the people that I'm doing it with, similar results have occurred. And the biggest difference between the two scenarios, or the extra information, is that you've now got these cases linked to eating this at the same place. So you've got a common exposure, and that then increases our level of suspicion that we do actually have an outbreak occurring. So, oops, sorry, Nick, I forgot that bit was there.
So you're now having a meeting with your colleagues. Some of you may be doing that where you are actually talking about it. I think some of you are together with other colleagues to go through the details and decide that this is a potential outbreak that you need to investigate.
So this then brings us on to step 2, which is when we plan our investigation and form an outbreak investigation team. Now, often this step is kind of overlooked because you're all very excited, you've got an outbreak, you want to run and start investigating it, but it is really important to sort of stop and decide who's doing what, who you need on your team, and the roles and responsibilities. Now, if you're a public health unit or any organisation involved in an outbreak, you should already have an outbreak plan. So you should pull that out and work out how you're going to tackle this particular outbreak. The team that I've got up there is what we refer to as our simple outbreak team. Not everybody that is involved in the investigation will be on the outbreak management team. This is more of a representative team of the main groups that are involved in an outbreak. And you can see here we've got a coordinator, public health practitioners, environmental health officers, epidemiologists, and admin officers. Although for a lot of you that work in government departments, you'll all know that we do our own admin most of the time. So if you get an admin officer, that's usually an added bonus. The responsibility of the team is to coordinate the activities involved in your investigation. As I said before, it's not everybody that's involved in the actual conduct of the investigation, but it is that sort of high-level oversight. So they will meet regularly to report on what's been done, review the data that's been collected, decide on next steps, and then finally decide and declare that the outbreak is over.
So here's your investigation team that you have formed. So with the team lead of the enteric section as the outbreak coordinator, you have also 2 public health officers, the AusFoodNet epidemiologist, and some of you might be aware of AusFoodNet. That's a coordinated group of epidemiologists throughout Australia that work on foodborne disease outbreaks, and an environmental health officer. So all assigned to the team, and you are about to hold your first meeting to plan the initial outbreak steps.
Fabulous. So then moving on to step 3, the first thing that we like to do once we've decided to investigate an outbreak, we've got our team together. We typically have our first meeting, and here we will define, work out how we're going to find, and then we'll count all of our cases. So if we just go through those 3 components one at a time, firstly, we need to define our outbreak cases. So who is it that we are going to include as someone that's part of our outbreak? And we typically have 4 criteria. We have the disease or the health event, so the illness that we're looking at too, and then we include our person, place and time information that links those people to the outbreak. You'll hear the phrase person, place and time mentioned all the time. It's one of sort of the standard epidemiological assessments that we do. And here, this is what pins these cases to being part of our outbreak. So that's step 1. Once we've defined our cases, we then have to go out and find as many as we can. So typically the ones that we hear about first are just the first few of many, and we want to go out using active and passive methods to find as many outbreak cases as possible. There are lots of different ways we can do that. Some are more active than others. We can do screening, as shown in the picture there. We can call up hospitals, doctors, and ask them to report cases or to test cases that fit a clinical case definition. We can put alerts out in the media. There's a whole raft of methods we can use to try and get as many cases notified to the public health unit as possible. Once we have those cases, we then count them. And I'm not just talking about the total number here. I'm talking about counting them and collecting initial information. Now, if this is a notifiable disease that I talked about a bit earlier, we can often get this information already because it's part of the notification process. Sometimes, though, we will have to interview our cases and gather that initial information.
Okay, so in this situation, the definition was a possible case was an individual with diarrhea and either vomiting or fever with an illness onset after 1 January 2011 and who lives in the local public health unit area. That's your case definition. So to find cases, the public health unit requested daily reports from the 5 emergency departments closest to the bakery premises. GPs in the local area and other public health units were alerted to the outbreak and asked to report possible cases. And cases were interviewed using a standardised questionnaire to confirm exposure, onset date, symptoms, date of exposure and foods consumed.
Fabulous. Once we've collected that initial information on our cases, we then move to step 4, which is to do our descriptive epidemiology. And again, we come back to our time, place, person, slightly different order. And this is where we describe our cases by those 3 factors. So we characterise our outbreak cases, we put the data in a line list, and we do tables, figures, and other types of analyses. The reason that we do that is because it tells us about who is getting sick through the person analysis, where they were when they got sick or where they lived when they got sick, and when it was that they got sick. And from those relatively straightforward analyses, it can tell us a lot about the outbreak. It can tell us about potential groups of people that are at higher risk. If, for example, there's more males than females, more younger people than older people, that can give us clues about potential sources of an outbreak. When we look at places, if it's from a particular, everyone went to the same bakery or everyone went to the same wedding or they're all school children, that can tell us a little bit about where they were. And with time, we can plot an epidemic curve, which can tell us lots of different things. It can tell us if everyone was exposed at the same time. For example, they all ate a particular restaurant at the same time, they're usually always sick within one incubation period. If we look at the epidemic curve and there's lots of cases over a long period of time, we know that the exposure is ongoing as well. So by doing these relatively straightforward analyses, it can tell us a lot about what's going on in the outbreak.
Thanks, Michelle. So our descriptive analysis, who is it? So starting with person. I don't know whether anyone would like to pop in the chat anything about the people. Is anything standing out to anyone about the cases? Not seeing anything in the chat. So looking at this table here, we can see that 74% of them were female. And most of them, the majority of them were in the age group, the young adult age group, sort of 23 to 39 years. Kelly's got a hand raised. Yeah, thanks. So a few persons. So we've got a couple of questions there. One is, could this situation be food poisoning? Is food poisoning an outbreak? Yes, it is. And yeah, another person noting that there are more females than males. Thank you for that. So yes, person. So there's a little bit about person. And what about place? We found that all the cases were from the local area of the public health unit, and most of the cases reported eating at the same bakery in the local area. And the time period here, this graph's showing you two things. We've got date of onset in the darker blue and date of purchase in the grey colour. So you can see over there, from there, where we've had a sort of, and a bit of an explosion of cases over that time period, 2nd of January through to the 6th.
Okay. Once we've done our initial descriptive analysis, and we may have more questions than answers from that, we then move on and into step 5, where we generate hypotheses about the cause or source. So we might have a few ideas based on our descriptive analysis where we'd like to go further with our questions. And we then essentially systematically collect exposures from a sample of our cases to determine what they have in common. So here we do another interview where it's a lot more detailed, and we ask them about pretty much everything they did, everything they ate, everywhere they went in the period before they got sick. The types of questions that you ask will depend on your pathogen. So if it's a foodborne pathogen, you're going to be more interested in asking about what they ate. If it's a pathogen that's linked to travel, you'll ask about where they've been. For example, if it's a Legionnaire's outbreak, you'll ask where they've been in terms of vicinities to cooling towers, for example. There's a couple of example questions there. We typically ask two types of questions in our hypothesis generation, either trawling or shotgun questionnaires. Trawling questions are very open-ended. What did you eat for lunch? Where did you go on Tuesday? And again, as I said, the topics depend on the disease. Shotgun questionnaires, on the other hand, are yes/no questions. Did you eat cheese before you got sick? Did you go to the city before you were sick? And when the case answers yes, you then get further information. So where did you buy the cheese? How often did you eat it? What was the use by date, etc. Once you've done that with a number of cases, you then have to sort of tally or assess all of that information and try and work out if there's something in common with the cases. So the easiest way to do that is to tally all of your foods. I do say easiest, it's actually not easy, because as you can imagine, if you're asking people about what they ate in a 3-day period, and you've got 15 people and you've just got a long list of foods that they ate over those 3 days, trying to work out what's in common can be quite challenging. We simplify it by putting up a little tally there. So that's one way that you can do it. And you then work out, well, is there a food on that list that looks like it's a bit more in our outbreak cases compared to what you would expect? So you do then have to make some sort of assessment. You might go, oh, look, 16 of our cases have eaten pizza. Is that unusual? And you might compare that number with a previous outbreak. You might compare it to a survey that's been conducted about food frequencies, or you might just go around the room in your outbreak group and just say, who's eaten pizza in the last 3 days? And if it's not the same proportion, if it's higher or lower, that then may lead you to that being your hypothesis. I've presented this as quite a simple and straightforward process. This is often the hardest step, getting a massive information and trying to work out, well, what are my 4 or 5 hypotheses? Often you might go back and re-interview cases, you'll redo the analysis. It is quite a long and challenging part of the outbreak investigation. Ideally, your outcome, though, is a short list of potential exposures that you can then test in the next step. But before we get to that, let's just see how we went with our New South Wales outbreak.
Okay, so the hypothesis generation resulted in us having a detailed food history for the 3 days of preceding illness onset, and the first 26 cases were able to be followed up. Of these, 21 of them, or 81%, had consumed food from the same bakery. And a quick survey of the outbreak investigation team found that only 1 had ever eaten there several months ago. So you can see how that would have provided quite a clue. So the hypothesis for this then is that the outbreak was caused by a contaminated food item from the bakery.
So fortunately for this outbreak, they were able to come up with a hypothesis, and they were able to move to step 6, which is to then test that hypothesis using epidemiological investigations. So this step 6 can only be done if you've got a hypothesis to test. It's not done for all outbreaks, only those where you do actually have something to test and an appropriate sample to do an analytical study. And the aim of our analytical study is to test our hypotheses, it's quite a mouthful, by comparing them, so comparing the exposures between our outbreak cases that fit our case definition and a group of people that are not sick. And we basically want to see that there is greater exposure in our outbreak group compared to our people that are not sick. There are 2 main study types that we do. The first is a cohort study, and we do a cohort study when our population is a defined group. So for example, if we had an outbreak at a function, like a wedding ceremony or a school camp, we know who was there at the time that the exposure occurred. Everyone in our cohort had the opportunity to eat the dodgy bit of food, so we can do a cohort study. And in a cohort study, we calculate what a relative risk. And essentially what that is that we're comparing the proportion that got sick in the group that were exposed, so those that ate the particular food, to the proportion that got sick in those that didn't eat that particular food. And we do that calculation for all of the exposures or all of the food items at that particular event. It's often quite obvious when you're going to do a cohort study because you've got that defined group. The other type of analytical study we do is called a case control study. And we typically do these where we don't have a cohort. So for example, if you've got an increase of a particular disease across a jurisdiction, your cohort's going to be that entire jurisdiction. So it's not practical to interview everybody in New South Wales. So in this case, we do a case control study. We acknowledge that we're not going to get the full cohort. We're not going to get everybody that was potentially exposed, but that's okay. What we can do is compare our cases that fit the case definition with a group of people that don't have the illness that don't meet the case definition. And what we do here is we actually calculate an odds ratio, and here we're comparing probabilities. So we're not comparing risk, we're comparing the probability of a case being exposed with the probability of a control being exposed. Over to you, Nick.
Okay, so clearly we needed to do a case control study here. This is a bakery environment. So a case control study was conducted between the cases already identified. So cases were asked to nominate friends or family that had also eaten at the bakery as control. So that's one of the methods that you can use there. A vast array of ways that you find controls to study, but this is a very a good one. It's a good way to find controls. And here's a table of what these interviews were able to determine. So again, I'll just give you a minute to look at this. So we've got the exposure there, the vanilla slice, chicken rolls, pork rolls and lamington. And we've got cases and those that reported being exposed and those who reported not being exposed, in other words, eating them or not eating them. And then the same for the controls. And from that, we're able to have a, determine an odds ratio. So thank you. I can see that you're already jumping in to the question, what do you think caused the outbreak? So I'll give you a bit of time to look at that and try and make a determination. Answers are still coming in. Thank you. While you're doing that, I'll just also apologise for my throat. I've just got a little bit of cold, so apologies for a bit croaky and having a few drinks. Okay, looks like it's slowing down. Oh no, a few more coming in.
Keep going to stop it and then another one comes in, so I'll just hold off for a little bit longer.
Okay, stable there at the moment. Okay, so from your responses, we've got 94% of you have nominated the pork rolls as being the food that's caused this outbreak. And then we've got 4% saying vanilla slice, 2% saying chicken rolls, and none of you saying the lamingtons. Thank you very much for that. Just move that so I can. So that's tricky, isn't it? I can't remember what's on the next slide, so I don't want to give away Michelle's next bit. But when there's more than one food, which you'll usually find more than one food with elevated odds ratio, that's not uncommon. So then being able to determine which of those is the suspect food. Do you want me to continue, Michelle, or are you talking about this on the next slide?
No, go ahead.
Okay. So again, sorry, someone said you couldn't use the chat, but you can write in the Q&A if that's still right. Yeah, Michelle's nodding. So would anyone like to suggest why that you might have a increased odds ratio like that? And a lot of you said pork rolls, but what then do you make of the chicken rolls having an increased odds ratio and a slightly, though not much, with a vanilla slice? Any thoughts about why that might happen? No one having a go. That's no problem at all. Of course, one of the reasons
there's a few in there now, Nick.
Oh, there's some there now. Great. Okay, so some of the responses we've got, similar preparation facilities, absolutely. So there could be a cross-contamination happening. That's very common. Someone else has suggested the person handling the foods. That's absolutely something you see. If it's a viral illness, it can be the food handler. Incorrect cooking and incorrect cooking temperature, absolutely. That could be a reason for it as well, and it could be more than one food has been handled that way. Yeah, so again, another person asking about the person preparing not washing their hands. Again, that's mostly relevant if it's a viral pathogen that you're dealing with, whereas if it's a bacterial infection like a salmonella, that can still happen. Food handling and food washing, hand washing is extremely important, but we see that more commonly in viral outbreaks. What else have we got there? That it could have been a food handler. Yes, absolutely, same thing. Yeah, so it was pointed out that more people were exposed to the chicken that didn't get sick as opposed to those with the pork rolls. That's absolutely right. And of course, the other thing is a lot of the cases could have eaten more than one thing. So that's very common that you find elevated odds ratios, but it could just be a lot of those people that ate pork rolls also ate chicken rolls, and maybe some of them ate the vanilla slice as well.
Another reason could be that there's a similar ingredient in the chicken rolls as there is in the pork rolls, or, which is highly likely in my family, you forget if you had the chicken roll or the pork roll. So you might not realise what meat you've eaten, so you accidentally choose the wrong one when you're filling out your questionnaire.
Right, thank you.
Before we move on, the other thing that we should just mention is this actual outbreak didn't actually do a case control study, so the data in the table is actually made up. So don't quote any of it if you're talking about it later. All right, thanks, Nick. Oh, so we've already done that bit, what we cause the outbreak. Okay, so usually at the same time that the epidemiologists are doing their epi study, their case control or their cohort study, we also have other investigations going on. So we usually have an environmental investigation, laboratory investigations, and sometimes other ones as well. So this is step 7, although it's usually done at the same time as step 6. So our environmental investigations are looking at how and why the pathogen got into the environment, and then how it spread to cause illness. And there's typically 2 components. The first are your contributing factors. And I sort of think of this as, well, how did the pathogen get into the environment? Here you've got to consider what was the initial contamination event? How was the pathogen able to survive? And how was it able to proliferate? The second component is looking at what's called the environmental antecedents. And this is what were the other factors that allowed the contributing factors to occur. For me, I think about this as the human component. So what are the people doing? What are the processes? What are the equipment? What are the economics at play that means that this contaminated product can be in existence in the environment? And you might think of things like, inadequate training leading to cross-contamination, economics, you don't want to spend money on expensive cleaning products, so you don't, those sorts of things. So that's what we do our environmental investigations. Not all in outbreaks will have one. You do need to have an implicated premises before you can go and investigate it, and there's a list of particular places where site inspections may occur. The other part of the environmental investigation is taking samples and having those tested. And ideally, if those are tested and they have the same pathogen as our cases, that's further evidence that it was that environment that caused that particular outbreak. Over to you, Nick. I thought there was another slide for me, but no, straight to you.
Okay, so for this investigation, the premises, so the bakery, an inspection was conducted of the bakery on the day the outbreak was notified, and that include looking at the food handling, cleaning practices and cooking methods. Environmental swabs and food samples were both collected, always great when that can happen. And then a trace back of the suspected food served at the premises was initiated, and it was found that raw eggs were used. So here I believe this is from the outbreak that we're describing. This is the real deal, not the made up table from the previous one. This is what actually happened. They did find a number of breaches. So the environmental investigation uncovered quite a few, and you can see there that under the Australia-New Zealand Food Standards Code, there are a number of breaches, and you can see the codes that they come under there on the right-hand side of that table. But essentially, cooked pate was cooled at room temperature for up to 4 hours. There was inadequate temperature monitoring of the pork belly during cooking. No doors on the chilled food display cabinet, and that meant there was no temperature monitoring or control. Eggs were stored at room temperature. Food equipment wasn't adequately cleaned or sanitised. This bakery sounded about a bit of a nightmare, isn't it?
Wait to get to the next one.
Food mixer whisks were stored on the floor. There was inadequate kitchen hand washing facilities and poor hand washing practices by staff. So a number of things that weren't being done adequately within this particular premises.
My favourite, and I've not seen it anywhere else before, is that the food mixer whisks were stored on the floor.
Yeah, that's classic.
All right. The second part, I should say the third investigation that we do is a laboratory investigation. And in an outbreak, this is typically done by a public health laboratory, not the laboratories that you go and get your individual clinic samples for diagnosis purposes. These are laboratories set up to do confirmation testing, tests to differentiate our pathogens, and basically work for public health purposes. And in an outbreak, the public health lab has 2 roles. They typically at the beginning help us detect outbreaks. They contribute to the surveillance system when they have positive cases that are then monitored for those spikes. And then during the outbreak investigation, the laboratory will receive specimens from the cases, from the environmental investigation and from food samples, and they are all tested to see if the same pathogen is in all three. There's lots of different types of tests that the labs can do. We're all very familiar now with whole genome sequencing, thanks to COVID. That has become the gold standard, but there are lots of other types of tests that can be done. And you can see in the box there, they're divided up into two types. The first are your phenotypic testing, which is looking at function and sort of traits of the organism. I kind of think of that as, you know, eye colour, hair colour. And then your genotypic is looking at your nucleic acids, so your DNA, your RNA, and there's a variety of different tests that you can do there. The pictures there, the first one actually shows a culture being grown, so that's the actual pathogen being grown in that little plate. And then this one, it's probably very small, shows you what we're getting more and more used to, which is the tree that comes out of your whole genome sequencing. So the branches on these trees show the relatedness of those particular specimens, and you can use that relatedness to tell if the specimens are of a similar pathogen or not.
So for our lab investigation, there are a number of specimens that were positive for an outbreak strain of Salmonella typhimurium MLVA type 310.89523. MLVA typing was used a lot before the whole genome sequencing became more used more often. It was used a lot, and those sorts of codes might seem a little bit foreign, but to me it was like just part of the language that you learned. So this particular outbreak was of that type. 47 of the 49 human specimens were positive for that strain of Salmonella. 62% of the 21 food samples were positive. That included raw egg butter, chicken liver pate, chicken, pork, and various salad ingredients. And 45% of the environmental samples collected within the bakery were also positive. So this is the trifecta. We don't get it that often, to be honest, for a variety of reasons. You might not already get all of those samples, and when you do, you might have tested a bit late, or there's all sorts of reasons. But this is kind of a bit of a trifecta where you get the human, food, and environment all positive for that very distinct strain of Salmonella typhimurium infection. So yeah, we get pretty excited when in a outbreak investigation you get that amount of evidence collected to support your findings.
Excellent. And when you do get that trifecta of evidence, it makes this next step a lot easier. So step 8 is when we implement our control and prevention measures. And you can imagine that if you've got that strong evidence that's linking a group of cases with a location and food samples, it's a lot easier to convince the powers that be to close restaurants or implement other types of prevention measures. So that's what we do in step 8. Although I should say that we don't wait until we have all of the information from the investigation to implement control measures. We can do that right from the get-go based on what we know about the pathogen, what we suspect might be the sources, what are the probable modes of transmission. So right at the beginning, you can start telling your cases, and you can put out guidance as to some control measures. And then once you figure out what the source is, you can then go and implement more targeted control measures aimed at either the outbreak source, the suspected vehicle or transmission route, or at preventing those susceptible humans from coming into contact with the source. So they're the 3 areas that we aim our control measures at. And just to kind of give you a few examples of what those are, in terms of the outbreak source, that's where you actually stop the source from being contaminated. So you can do that by closing a premises and insisting that they clean it very thoroughly. You can modify procedures. You can pasteurize your eggs. You can cook at a higher temperature to kill pathogens, or you can clean or disinfect the actual source of that outbreak. If the outbreak is linked to a vehicle, the pathogen is linked to a vehicle or transmission, you can actually remove that item from the human pathway. So you can do a recall or removal of a contaminated product, or again, you can treat or pasteurize that vehicle or transmission route. To prevent susceptible humans from coming into contact with the outbreak pathogen, you can provide education. So you can say, please make sure that you cook your chicken and eggs thoroughly. You can give them instructions on what to do. If they've got a particular source, like a boil water notice, you can tell them to throw away anything that may be contaminated, or you can educate them to prevent them from coming into contact with vectors and other things. Let's see what they did in this one.
Yeah, so the control measures that we've implemented for this outbreak we're managing at the moment included closing the premises. So the New South Wales Food Authority served a prohibition order to the bakery that closed the business until the following conditions were met. All equipment needed to be cleaned and sanitised. Fixtures and fittings had to be verified free from salmonella by the New South Wales Food Authority, and food handlers had to demonstrate adequate skills and knowledge in food safety and hygiene. So the business agreed to permanently cease production of raw egg butter as part of this as well. So there was that education moment for them where they decided, this is obviously a very big deal when something like this happens to a business, and it's great when you see that they take a learning out of it. So not only were they fixing the problem, it was the immediate problem that were there, and improving the knowledge of their food handlers. The use of anything with raw eggs is always risky, and needs to be, and in some cases, in some states, in some jurisdictions, it's not allowed at all. In some jurisdictions it is, but it has to be done in a very controlled way. So this business decided not to use raw egg butter anymore.
Right. We still have 2 more steps to go. We know the last one is to declare the outbreak over. Step 9 is actually one that, again, like control measures, should be done the whole way through the outbreak investigation, and that is to communicate your findings. This is not about communicating to do your investigation. It's about communicating what you've actually found with certain groups of people. So there's a few different groups of people we communicate with. Firstly, we communicate with each other within the investigation team, and we do that through regular meetings, having contact lists, knowing how to contact people, and by producing situation reports, which are updated as new information comes to light. We also need to communicate often with the general public and the affected community, either to provide them with information that the outbreak is going on, tell them what to do if they've been potentially exposed, get them to come for treatment, or identify themselves if they're potential cases. And there's a picture there of Jeremy McAnulty from New South Wales, who often fronts up as the media person in that state. Sometimes we also have to communicate with the media, or use the media to communicate to the general public and the affected community. And we need to make sure that what we're giving to the media can be then used by them to communicate effectively to our public. And we can use the media to help us with case finding, again, to inform the public, maintain support, and just minimise conflicting information so that they know that the information is coming from the actual outbreak team. And then finally, if we're a public health unit, we often need to communicate within our jurisdiction. So the public health unit might talk to other public health units. They might need to talk to the Department of Agriculture, to food safety people within their jurisdiction. They may need to report that outbreak nationally, and sometimes even internationally. And there's lots of reporting requirements according to the international health regulations and our National Health Security Act within Australia as well. We won't go into too much detail about those.
So in this, thanks. Yeah, in this instance, actually, I think this one's actually not associated with it. Sorry, this is an example of how you would produce a media release, and I'm sure all of you where you're calling in from have seen similar types of media releases at different times. So this one was about an investigation on the Central Coast of New South Wales about a salmonella outbreak, and you can see there that New South Wales and the New South Wales Food Authority are together producing this media release and providing the public with information on their continuing investigation of quite a significant foodborne outbreak following a conference that was held on the Central Coast. So in this particular one, there were 69 people from New South Wales, Northern Territory and Queensland who were impacted. And you can see Jeremy's name there again. He's often the one out giving this information. So this is very a very common type of media release that you'll see. And where there are food authorities in the different jurisdictions, you'll often see this type of combined one coming out when they're working together.
Okay, thank you. Finally, we make it to step 10, which is when we get to declare the outbreak over. Now, this can take a couple of weeks and can take a long time. We saw with COVID, it kind of has never really stopped. But essentially, an outbreak ends when the number of new reported illnesses returns to what we would expect. So remember, we looked at that surveillance data. There's usually a background rate of disease. We'll have a spike, which indicates an outbreak. Once the numbers go back to that background rate, we can call the outbreak over. We typically use 2 incubation periods, so no cases within 2 incubation periods, just so that we're sort of doubly sure that there hasn't been another related case. And you can continue your surveillance to make sure there are no new cases. Sometimes you'll find that the cases stop. You declare the outbreak over and pack everything up, and then a few days later the cases start again. And that could either be because your control measures weren't as effective as you thought they were, could be a new outbreak, or it could be something else that's going on. So it's useful to keep a watching brief after that period. What you need to do once you've declared the outbreak over is a final report. Now, this might be a final SITREP that remains internal. You might need to write some other kind of internal report, or you might want to publish the outbreak so that you can share it with the general with everybody. And I would recommend trying to publish as many outbreaks as possible, even if they weren't, you didn't get that trifecta of evidence. It is really useful to learn how other people are doing outbreak investigations. The other thing that you should consider doing at the end of every outbreak is an after-action review. And this is where you consider what worked well, what could have been improved, and what you might change for next time. And the picture there is a template from Queensland Health that sort of shows how they sort of frame their after-action reviews.
So here's a summary of a gastro outbreak. This is a point source outbreak. As you can see, it's written up. So it's linked to the chicken, pork and salad rolls from a Vietnamese bakery in Sydney. There were 83 outbreak cases, 58 were interviewed, and all 58 cases reported consuming rolls from a single bakery. So you can see how this is really useful. This is the STM MOVA type 310-89523 that we found identified in the stool, food and environmental samples. You can see that the report is also reporting about the business producing raw egg butter, no pathogen control step and mixed ready-to-eat foods. Cross-contamination was evidence. There was a lack of food safety knowledge and multiple breaches, as we saw. And although the investigation wasn't able to identify the exact food source that introduced the salmonella onto the premises, the control measures undertaken stopped further cases. So in some cases, and I've been involved in some here in Tasmania a long time ago, it gives my age away, but back in the mid-2000s, when we had an ongoing outbreak of SDM 135A, another form of Salmonella typhimurium, and it had been going on for a very long time. And in the end, we actually were able to trace the eggs back to a particular farm. It was managed at farm level. That farm actually ended up closing. That was for other reasons, but the problem went away. So sometimes you can trace it actually. The initial source into the premises can be traced back, but in this instance, it wasn't the case. Thanks, Michelle.
No, I guess it's also worth mentioning that too, many outbreaks, you don't actually find out what caused them as well. So you might do, and lots of them stall at that hypothesis generation step as well. So if you are doing an outbreak investigation and you don't come up with a conclusion, don't worry, that's often the case. In fact, that probably happens more often than finding a definitive cause. All right, so that sort of brings us to the end of our 10 steps. I've just put them up there again so that you can sort of just refresh your memory of everything that we've been through. And also just to say that while there are 10 steps, you don't necessarily do all 10 steps for every single outbreak. And you don't necessarily do them in order either. I mean, some of them you have to do. Obviously, you've got to determine you've got an outbreak before you can do anything else. But others can be done at the same time, or you might start your control measures before you've done your descriptive epidemiology. It doesn't really flow in the way that it's presented there. I do have one final slide, and that's just to sort of introduce to you what our teaching options are at UTAS. And if you are interested in learning more, what we do have to offer. So in the sort of health protection space, and we do offer, as I sort of said earlier, short courses, a graduate certificate, and that's actually nested into our Master of Public Health. So I'll just quickly go through this, seeing that the time is quite close to finishing. I'll be very quick. So essentially we've got two short courses of 4-day duration, one on outbreak management, which goes through what we've covered today in a lot more detail. We've got lots of hands-on activities. We work through a different scenario, and we go through those 10 steps. We have a second short course in public health surveillance where we go through the different types of surveillance used in public health. We learn how to analyse that data, and we learn how to evaluate our surveillance systems. So they're offered as 4-day short courses. You can contact us and we can make arrangements for those to be run. If you do attend those 4-day short courses, you can complete assessments, and you'll then actually get credit for our units, our accredited university units in outbreak management and public health surveillance. And they form half of our health protection, graduate certificate in health protection. So you can do 2 of those units through a short course modality. You then complete our other 2 units in communicable diseases epidemiology, which I also teach, and environmental health, which is taught by a colleague of ours. They're run as semester-long online units. Once you've completed all 4, you get your graduate certificate in health protection. If you're still interested in learning more and going further, you can then complete a Master of Public Health, and those 4 units will count as your elective units within that MPH. So then you will need to go on and do our core units, which are required for the public health, and then you can choose to do a capstone or research pathway. And if you would like to, you can choose to do that research project with myself and Nicola on a health protection project. We've actually done, I think we're up to 3 or 4 now, and you can either bring a project with you if you work in health protection, or we have an agreement with the Department of Health in Tasmania where they have projects that we can work on collaboratively with them for you to complete your MPH. I think that's it. So please let us know if you've got any questions now in the Q&A. I remembered halfway through that the chat doesn't work. So you just use the Q&A button. And if you come up with any questions later, please feel free to contact either myself or our sort of generic health protection email, which is up there on the screen.
There have been a couple of things come up through the presentation, Michelle, that I've been answering as we go, but